On today's episode, we have Dr. Amy Killen. Dr. Killen is the Chief Medical Officer at Humanaut Health, as well as an expert in stem cell therapy for skin, scalp, and sexual health. Dr. Killen and I talked a lot about hormonal changes through each phase of life, how having PCOS as a younger woman may affect women older in life, as well as a ton more. I learned so much in this episode. I think you guys will too. Happy listening. Dr. Amy Killen, thank you so much for being here today. I really appreciate it.
Thank you. I'm excited.
I'm so happy to have you here in Florida. We're doing our grand opening of Humanaut Health.
Yay.
So we'll be over at the clinic later today and then tomorrow morning for a small event. And it just feels so special to have you here.
I'm so excited. I've been excited about coming and seeing the clinic. It looks beautiful from pictures. So yay, good job.
Thank you. Thank you. We worked hard at that. But yeah, so obviously we'll talk a lot about Humanaut today and just the ethos and how we practice at Humanaut. You're the Chief Medical Officer. So on our last episode, we were talking with Jim about this, I called it the A-team that he really put together of, you know, all of the medical leaders. And obviously you're the leader of the medical leaders at Humanaut. What drew you to Humanaut?
So Jim and I and Harry Adelson were actually the first three people to come together to kind of create Humanaut. Jim came to Harry and I, who'd been working together for a long time, and he said, I want to create this clinic that does kind of all the things under one roof.
Right.
That does all the things. And so we all three got together and said, okay, what are the things we want to do? Like, what should we bring under one roof? How are we going to do it? And so from that group, we ended up growing, the rest of the company. But we were excited. I was excited because I've been in this space, in this kind of health optimization, longevity space for 12, 13 years now, since leaving the ER. And I've done a lot of things in the space, but I've never done it all under one roof. And so I was excited about putting it all together. And so people really have like a one-stop shop.
Right. So you're really well known on social media. I found out yesterday that you're the most followed doctor on Substack, which congratulations.
Oh, really? That's surprising. I mean, thank you. I don't know if it's true, but I'll take it.
Somebody's out there saying that. So
I mean, I like that person.
What was your transition? You mentioned you started your medical or your doctoral career in the ER. What made you decide to go from the ER into this world of regenerative and integrative medicine?
Yeah, so I was in the ER for 10 years, and I'm board certified ER doctor still. And towards the end of that, I was living in Austin, and I had my 3 kids within 2 years. So I had twins, and then I had one more 20 months later.
Okay.
And when my third one was born, my husband moved out of state for a job a week later.
Oh, wow.
And so I was like the lone caregiver for this 3 kids, and I had to be at work at 4 a.m. for my ER job.
Oh my goodness.
And I did that for a while, and I, as you might imagine, kind of got a little burned out, like wasn't sleeping, wasn't eating well, wasn't exercising ever, just kind of frazzled. And I realized one day I was at the office at the ER, and I looked out at the waiting room, all these people kind of waiting to be seen. And I realized that if I didn't make some big changes in my life, I was going to be one of those people with a chronic medical problem that probably could have been prevented if we had gotten to it sooner. And something flipped in my head, and I realized that I wanted to actually be healthy and not just kind of put Band-Aids on things all day. So I started learning about this whole field, which wasn't even a field really, but all of this medicine, this integrative medicine at that time.
So where did you start? Did you start with hormones?
I did. I started with hormones and just kind of metabolic health. I started learning, about prevention and metabolic health and lifestyle and hormones. Okay. And then I eventually left the ER, opened my own practice in Portland, Oregon as part of a franchise. And I was a one-woman show. I had no one else. I had no nurses, no front desk person, no scheduler. I did it all myself, all the blood draws, everything. And it was interesting. I learned a lot.
I bet. I bet.
I had no idea what I was doing. But, it actually worked. I eventually sold that practice, and then I moved to Salt Lake City, which is where I live now, and was able to help grow another big practice, and then got into stem cells and some of the other things as well.
Oh, that's awesome. Yeah. I always joke because people will ask my husband and I, so if you guys aren't the doctors, what do you do? And we're like, So much. There's so much to do for a medical practice outside of operating as the physician.
I had never even like ordered medical supplies. Like I had this clinic.
Yeah.
I was like, okay, where do I go to get lidocaine? And like I had no idea. There's so many things that you are not taught in medical school. It's so nice to have people who can help you with that, but I didn't really have that. So we're glad to have people like you.
I bet. Well, it allows for you to do your job so well when you don't have to worry about ordering the lidocaine.
Yeah.
And I mean, I guess you do a lot of marketing just by making so much social media content as you do. But, you shouldn't have to be designing emails and thinking about, our full funnel structure. You get to kind of just be the talent more.
Yeah. The talent.
Yeah, the talent. Yeah. I know. It's like a fun term, isn't it? Before we totally move on from your ER career, I would love to know, do you have like your craziest story from the ER that you could tell?
Oh my gosh. People ask me this, but like all of my crazy stories are like the most depressing stories. Oh, like they're super sad. I do have one. Well, that was kind of depressing too. I feel like they're all a little depressing. One of my favorite ones was a guy who came in, rectal foreign bodies are big in the ER, right? Yep. Like it's all like, there's so many things that people put inside themselves. And, we always kind of joke around like, oh yeah, you fell in the shower, right? But one guy came in with an electric screwdriver and it was like enormous and the whole thing was inside of him. Wow. But the thing is, he didn't come in complaining of that. He came in complaining of abdominal pain. This is what always happens. They come in complaining of abdominal pain or something random, like I'm a little nauseated. And you do this entire workup to try to figure out why they're nauseated. And then at some point during the workup, you do like an X-ray or a CT scan and you realize that there's a screwdriver inside of them. And that's why they're nauseated.
Oh my gosh, if you're just listening, my jaw could not be wider right now. That is wild.
Yeah. He had to have surgery because he had perforated his intestines.
I'm sure he
had to have surgery, but he was very angry at like us. Like the next day, I was rounding on him, and he was cursing at me, and I was like, I didn't put that screwdriver inside of you.
Oh my gosh. Okay, that was a good one. Thank you for sharing. I ask because the Humanaut clinic nurse trainer, Shelby, used to work with you in the ER.
We worked together.
Yes, and that's what she is the most fun. I'll have to have her on the podcast one day.
She's so good.
But she had some wild stories from the ER of just like, it was mostly psych patients.
There was a lot of that. Yeah, a lot of that.
But we had a lot of fun while she was here training the team. So I had to ask you that one. Okay. So with Humanaut, you, Harry, Jim came together to begin with, and you started adding on all the other founders and executive team members. What was the gap you were seeing in the industry that you felt needed to be filled with Humanaut?
There are a couple of clinics out there who are doing some of the same things that we're doing. Mm-hmm. They're doing kind of like more like wellness. They're not doing the medical part of it as much. Like they're just doing some like maybe red light therapy, almost like Restore, like where Jim came from, which is great. I think it's fantastic. But they weren't doing like the more complicated medical part of it.
Right.
Or they were doing kind of all the things, but they were only catering to a very high-end client. Mm-hmm. And you had to have, an excessive amount of money to be able to afford it. And we wanted to create something that was available to all tiers kind of, of budget. And that, we had good medical practices and options for people who don't want to pay as much money, don't need as much hand-holding, as well as people who really want that kind of luxury experience. So we wanted to create kind of all the things, again, under one roof.
Right. We spoke about with Jim. It's an omni-channel solution, which is so helpful because, so many of our patients are on the move, whether they're executives traveling or they're, it's just, I feel like nowadays, you're in Palm Beach right now. You live in Utah. I'm sure you travel just as much as I do. We're all over the place. Yeah. We need that accessibility with our providers to be able to reach them wherever we are and have the structure in place so that if we need a prescription, if we need anything, we can get it. Yeah. But we also have the clinics, and right now there's 2. Over the next, I think Jim says, like over the next 5 to 6 years, there will be 100 over the course of the U.S., and then we'll look to expand internationally as well. But okay, so it was really just the breadth of solutions for clientele that you felt.
That was a big part of it. I also think that having the clinic available is important too. Yes. Because there are a lot of great telemedicine options out there. And I do agree that that's very convenient. Mm-hmm. But there's something also about going into a clinic knowing the staff, having the, the therapies there, being able to go like shake hands with someone, get your supplements if you want. There's something about that I think is really important, and that you kind of lose when you just have the telemedicine option. So that was also important, being able to do telemedicine, but also have the clinic experience to kind of ground people if they want it.
Right. And have them so tightly integrated so that it should be a very seamless process.
Yes.
So tell me, you have a lot of experience in stem cells and you specialize in skin and sex, correct?
Yes, that's right.
Tell me a little bit more about that. How can stem cells be used for skin and sex?
Well, the same properties that make stem cells useful for joint health or, back or any of the other things that people use stem cells for make them great for skin and sex. So, essentially the improving blood flow, the reducing inflammation, the activating the local stem cells that are already there to become more active and act more youthful. All of those qualities are stem cell qualities. And so wherever we put them, they can activate that tissue. So for skin, we use them to improve skin quality, and you're increasing collagen and elastin formation. You're increasing blood flow, so better glow to your skin. We can use them for hair to improve hair growth, quality of hair as well as number of hairs. And then I use them also for sexual health for men and women to again improve blood flow, improve the health of the cells in the tissues. So that's what's so cool about stem cells is we can use them for so many different things. And they don't change how they act necessarily, but the tissues around them change what happens.
Right. Yeah, I'm so excited that we're offering those treatments at Humanaut because I think it's something, we talk so much, and we'll talk today a lot about hormones and peptides and all of these things, but stem cells, I think, just continue. We need to talk about them more and more because they're so helpful for orthopedic regeneration, but I don't think people realize how helpful they can really be. Especially for sexual health. I think that's something that, I love that you're open about that side of the industry and you really have given a big voice to it because so many people we've seen, I had no idea how big of an issue it was for so many people until we started offering those treatments. And it's eye-opening to understand that, especially as people reach midlife, that blood flow stops flowing as well. And that can really impact your quality of life.
Yeah, it's crazy. I mean, it's like, 50% of men over the age of 50 have some degree of erectile dysfunction, and that number goes up by 10% per year.
That's crazy.
And then for women, it's 40% of women of all ages have some form of sexual dysfunction. And that's like them saying, I have a problem. That's not us labeling it. That's them saying, I have some kind of problem. So 40% of all, which is crazy. It's crazy to me. It's almost half of us.
That I didn't even know that.
Yeah.
Can you tell me more about that? So especially, I'm 31, for example. What do you hear a lot of, premenopausal women who fall into that 40%? What does that quote unquote sexual dysfunction look like?
So usually it's one of four things or a combination. So low libido is probably one of the most common things, just lack of desire.
Right.
It can be a problem with lack of arousal. So like the blood isn't getting to the area. You're not lubricated. You're not, engorged, et cetera. There's problems reaching orgasm.
Okay.
And then the last one is pain.
Okay.
And so, or it can be, any of the combination of those things. So any of those things are considered to be sexual dysfunction if those things bother you, if you have them and they bother you. And so then, it's 40% of women, and it's a crazy amount. And it often is just, any of those things. And what's hard about women is, it's true for men as well, but there's the mental emotional part is so important for women. And so it's not just about getting blood flow to the area. You also have to work on this sort of mental emotional part, also the hormone part, all of the things come into play.
So interesting. So is it typically an underlying hormonal imbalance that's causing the sexual dysfunction, or
sometimes
how are you going about treating that?
So I think about, for men and women, I think about it as kind of like a four-pronged approach. I think about the mental, emotional, social part. So everything that has to do with the brain. So how's your relationship, mental health, depression, anxiety, PTSD, sexual trauma, like all of those things obviously can affect things. And then the second piece I think about is the cardiovascular health. So blood flow, that's that piece. The third thing is hormones. Estrogen, progesterone, and testosterone for women, mostly testosterone and estrogen for men. And then I think about the structural support itself, like, the muscles, the pelvic floor, the things around it, the nerves, how, is there anything going on down there? So it's kind of all of those things, and then figuring out which one is the real problem or if there's more than one problem, and then kind of going after that.
So interesting. So interesting. Okay, so for hormonal health, at what age do you recommend women and men start monitoring their hormones?
When we talk about hormones in women, like sex hormones, like estrogen and progesterone, for instance, if you have regular cycles and have no problems, like you have no real symptoms or concerns, I don't necessarily think you need to get estrogen and progesterone checked because it's varying, goes up and down throughout the month. There's not usually a good reason to check it if you don't have problems. But if you have symptoms, like you have really bad PMS, your periods are really heavy, they're really irregular, you're having infertility struggles, you have menstrual migraines or anxiety or all of these kinds of symptoms, then certainly getting hormones checked, even as whatever age, 20s, 30s, anytime. Testosterone also, if you're having symptoms of low testosterone, it can be checked at any age because it's pretty stable throughout the month. Okay. And then the other hormones like thyroid and insulin and those kind of things, I do think should be checked preventatively, even in younger people, because we see problems that you wouldn't have symptoms necessarily, but we still want to correct them.
So for thyroid, would you want to check that? And testosterone, would you want to check that at 18?
Thyroid, I think thyroid and insulin and cortisol, you want to check it early. Yeah, starting as when you're an adult. I mean, even sometimes if you have symptoms younger than that, but on your yearly checkup, or if you're doing more than that, then those should be checked. Insulin specifically, like you're looking, we know that insulin resistance is a major driver of diseases of all sorts, and there's no symptoms generally. And thyroid, you usually have symptoms if it's very high or very low, but there is still a range where you can have, lack of thyroid function and maybe not have a ton of symptoms or not know that they're coming from your thyroid. Right. So I do think it's beneficial to check that one as well.
Okay. And then if somebody is having PMS symptoms, for example, they should check their estrogen and progesterone as well, correct?
Progesterone specifically. Okay. Like if their cycles, if cycles are regular, estrogen is usually okay. Usually. But progesterone, it can very commonly not be going up enough in the second half of the cycle. Often you're not ovulating, and that's why if you don't ovulate, you don't make enough progesterone because you have to be ovulating to make progesterone properly. So you can check progesterone at like day 21 of your cycle or 7 days after ovulation, and that's a really good clue on whether you're ovulating. And if you have low progesterone, it also could mean any other number of things. It could be from stress, it could be from lack of sleep, it could be from any kind of other hormonal problem like PCOS can cause low progesterone. So that's an easy one to check, in 21 day of your cycle to see if it's getting to be high, if it's high enough.
Okay. And if it's not high enough, what do you do?
You have to start looking for causes, and certainly ruling out there's so many things that can cause it. Like, low thyroid can cause it to happen. Stress, not sleeping. And there's 1,000 different sort of things, some medical, some more like mental, emotional, that can cause it. Looking for PCOS, which is also a big cause of lack of progesterone. So it's kind of then about investigating what are the different potential causes and then zeroing in on what we think is actually going on.
Okay. Understood. So say you identify, stress was the cause of low progesterone. Obviously, doing what you can for the person's lifestyle so that they can start mitigating their stress. But if they're suffering in the meantime, would you supplement with a low dose of progesterone, even for a younger person?
Yeah, absolutely. We definitely can. I mean, certainly working on lifestyle is important, and we always want to do that. But you can absolutely give progesterone just in the second half of the cycle. So just from like day 14 to 28-ish, depending on the cycle length. And that kind of mimics what your body would be making or supports what your body is already making. And it can be really helpful for like PMS symptoms, for instance, or premenstrual migraines or premenstrual anxiety. All of those things can be made worse by low progesterone in that second half. And so by just adding a little bit, it's super safe. It's very easy. It can help you sleep. It can be really beneficial, to kind of get you through that premenstrual part of your cycle.
Yeah. I personally am on that. I had this like peak of stress where I got married and I got COVID in the same week, and then it was just this kind of peak of mental, emotional, and physical stress all at once. And I developed mast cell activation syndrome afterwards, which then triggered, hormone imbalance and thyroid imbalance. And all of a sudden I went from having pretty perfect hormone levels for a few years to 0 progesterone and getting on progesterone in addition to some antihistamines has been very, very helpful.
Yeah, that's good. Yeah, COVID really messed up a lot of things. And I'm not saying COVID necessarily did it, but we're seeing now that COVID, it causes like almost like rapid aging in like all different tissues. There's we're learning every day new things that have been messed up by COVID. It's crazy.
Crazy. I know. And I always say I actually tested for COVID and was negative. So it's like whatever variant of COVID or virus. It's some sort of crazy virus that just really threw my body through a loop. In addition to, like I said, I was definitely stressing myself too much beforehand, which is likely why I got so sick to begin with.
Yeah.
But yes, it was just this like huge curve that my body went through, or spike that my body went through. And it just like, we're almost 2 years later and I'm like still kind of trying to heal from this process.
Yeah, I think that, young women they kind of have gotten left out a little bit of a discussion. There's a lot of people out there talking about menopause now, although there wasn't 10 years ago when I started doing this, in perimenopause, which is, 5 or 10 years before menopause. But there, I think, are still more discussions to be had in the 20-year-olds and the 30-year-olds who, have just been kind of told to suffer in silence and like, this is normal, suck it up kind of stuff.
100%.
And it's it shouldn't be painful. You shouldn't have debilitating pain with your periods. You shouldn't be bleeding through your jeans. You shouldn't have mood changes so severe that your husband doesn't recognize you. Like you shouldn't have irregular periods, or you shouldn't be skipping months. Like there's so many things that really shouldn't happen.
Right.
And we should do a better job as doctors and educators about like looking into those things.
Yeah, it's truly a big reason. I mean, I even got into this industry and, started businesses like Pure Form and got involved with things like Humanaut. And then even started the podcast because I had so many people in my personal life asking me about the experiences that I've gone through and who I've worked with to heal so much of this stuff. Because like I said, I mean, I was diagnosed when I was 15, and prior to this whole MCAS journey, I was feeling really good. I had finally lost weight. I had finally brought that inflammation down. I carried an extra 30 pounds for 10 years. And, I'm vain like the rest of us. Like that sucked. Like it did. It sucked. Like I hated it. And I always joke that like more than half the reason I got into all of this stuff, I got licensed as a health coach, and I just like tried to learn as much as I can, was because I just wanted to lose weight so bad. And it was so hard for me. But there's so much, it's not, there's no magic pill. But there's so much that you can do to heal yourself. But yeah, there's just so many factors that end up with so many women having PCOS and they don't even know it.
Yes, about 70% don't know it.
That's crazy.
Yeah.
I didn't even know that stat. Okay.
Yeah.
70% of women that have PCOS don't even know it.
Exactly.
And do you know what the percentage of women who have PCOS is?
It's between 6 and 13%, depending on what stats you look at. So about 10% of women have PCOS, and most of them, 70% don't know it.
Because I was going to ask you, I feel like, especially now with TikTok and everything, I feel like I'm grateful so many more people know about PCOS now. I mean, when I was first diagnosed, people were like, what disease do you have? Like, what is that? And now it's more of a commonplace. Most women have heard of it, even if it's not personal to them.
Yeah.
They know a friend who has it. They have an idea of what it is. Do you think more women are getting it, or just more women are learning about what it is that they have?
That's a good question. I mean, I wouldn't be surprised if more women are getting it, because it is, PCOS, as you know, it is not actually, it's polycystic ovarian syndrome, but it's not really a primary ovary problem. It's an endocrine disorder that affects your entire body. Right. And it's, we see high, usually, and it's a combination of these things, but not all of them all the time, which makes it confusing. But, oftentimes high androgens, so testosterone, DHEA may be high. Oftentimes, most of the time at least, some kind of insulin resistance and inflammation associated with that. Sometimes cysts on the ovaries, like lots of cysts on the ovaries, which we can see on ultrasound. Sometimes, but not that common, you're super overweight, or maybe you have extra hair growth on your face, or male pattern baldness, or some of the things that we think of like classic PCOS symptoms. We see that sometimes, but it's kind of a hard thing to diagnose because there's not any single test that we can do that says yes or no, that this is PCOS. It's really a combination of clinical presentation, like symptoms you have, plus several different tests that kind of look like this thing.
Okay.
So it's a little tricky to diagnose. And so I do think that there's more awareness about it now. But I also wouldn't be surprised if we have higher levels just because of the environment that we live in.
That's what I was going to ask, just because, even aside from the food that we eat, which is the biggest factor.
Yeah.
Even just the amount of microplastics that we're all exposed to on a day-to-day, and mold that so many people are exposed to. There's just there's so many glyphosates
And
so
endocrine
many
disruptors. There's so many of those out there.
Right.
That mess up the entire kind of hypothalamus pituitary gonadal axis.
Right. Yeah, no, there's just so much that contributes to it all, but I am glad that we're talking more about it so that more women know the other factors. I mean, I think GLP-1s have been an absolute game changer in terms of treatment.
Yes.
It personally makes me very happy that we have something besides hormonal birth control to help treat this, because I think hormonal birth control, for me at least, felt like we were slapping a very flimsy Band-Aid on things. And it was like, I didn't have facial hair anymore, but I think it made me even more overweight. Because I was just I had so much more estrogen,
Yeah, it's not addressing the insulin resistance. It's not addressing the weight, the visceral fat, the extra visceral fat around your organs.
Right.
It's not addressing it may make those things worse.
Right. And I personally I did like a microdose of a GLP-1 a few months ago, and it really helped. Even just, even with the inflammation of the mast cell, it really brought things down, and just felt like my body went,
those drugs are amazing.
They are.
They're amazing.
I know. And I just got off because I want to start trying to conceive in a couple of months. And I'm like, ooh, that was really nice. I'm not feeling quite as good as I was. I'm feeling better than I was before starting, which is good.
Yeah.
But yeah, I had paired that with some BPC 157 and thymosin alpha 1, which happened to be a great stack for me personally. And yeah, it was working really well.
That's great. There are all these Ozempic babies now, people who maybe had PCOS or other things, couldn't get pregnant. They get on, Ozempic and other GLP-1s, and then they end up getting pregnant, thinking that they can't even get pregnant because they've been, dealing with infertility so long. So there are all these babies now that have been born because of that.
I know. And that was actually a funny reason. I felt so silly because I'm like, I talk about this stuff every single day, and I had just never asked our practitioners, what's your recommendation if you're intentionally trying to conceive?
Yeah.
Because I had always heard Ozempic babies. So I was like, as soon as I get pregnant, I'll just stop giving myself the shots of everything. And they were like, no, our recommendation would actually be to get off for a solid 90 days beforehand.
It hasn't been well studied, I think, in that regard. So we just, we're always a little bit careful.
Right. As careful as we can be, of course. But yeah, it was a funny thing that I'm like, oh my gosh, I'm just as bad as everyone else out there listening to the media, hearing Ozempic babies, thinking it's like a fertility drug.
Right. Right.
Okay. So as someone with PCOS, what should I expect as I age into perimenopause, menopause? Should I expect a different journey than a non-PCOS woman?
So PCOS doesn't go away just because you go through menopause. And certainly the ovarian cyst part of it is not really a problem anymore because you don't have the big fluctuations in FSH and estrogen and those hormones. But the insulin resistance, androgen, high androgens part doesn't necessarily go away. Sometimes, in general, testosterone and other androgen production in your body goes down as you get older.
Okay.
So oftentimes that's helpful for women who have PCOS because, their testosterone at 25 was much higher than at 55, just because that's just what happens. Your adrenals make less and your ovaries make less, usually. But some women, the symptoms get better because of that. But if not, then you can still have the androgen symptoms and then kind of chicken and egg to the insulin resistant symptoms. Those things kind of go hand in hand a lot. So I would say the journey is similar in that you still may benefit from replacing hormones like estrogen and progesterone. I still think that's worth that discussion, but you may not need a testosterone, for instance, because maybe you're still making enough. Everyone's a little different. Some women, lose testosterone faster than others, and even women who don't have PCOS, not everyone needs testosterone.
Really?
And everyone loses estrogen and progesterone at menopause. That just always falls off a cliff. You have no control. There's nothing you can do about it. Lifestyle doesn't change it. It always goes down. Testosterone is going down slowly from age 25, but the degree of that decline is pretty variable. And so not all women does it go down very quickly. And there's probably some lifestyle pieces. We know in men that testosterone is, it's supported by heavy lifting and sunshine and vitamin D and, good sleep. All that can boost testosterone in men. It's probably true that that can help boost it in women as well. It's just not as well studied in women.
Oh, so interesting. I didn't realize that. And when you say estrogen and progesterone drop off a cliff, is it truly like you just, wake up one day and over the course of a couple months, you don't have hormone, like you don't produce those hormones anymore?
It's more like a couple of years. Okay. And it's a slight, usually, so that's the perimenopause. So perimenopause is that 2 to 10 years before menopause.
10?
2 to 10.
Whoa. Okay.
So it can start as early as 35 and still be considered normal. Earlier if you have premature ovarian insufficiency. But normal can as early as 35, perimenopause. And usually the first thing that goes down is your progesterone starts to trend down first. And then your estrogen in the early perimenopause is actually going up even higher. So you're getting these chaotic bursts of estrogen that are very high, and then it's kind of coming down. So that's why perimenopause is so stressful, because you don't have any control over these. Estrogen may go from a normal of 300 or 400, and now it's 800 one day, and then it's crashing back down again. But ultimately, over time, they're both going down. Until you get to the point where when you run out of eggs, when you're down to about 1,000 eggs in your ovaries, that's when you're in menopause. And that's when both of those hormone levels are very low.
Okay. And then how does that interrelate with fertility? So say somebody starts the perimenopause phase at 35. They can still get pregnant?
Yes, usually.
Okay.
Yeah, you can still get pregnant. You're still ovulating. If your cycles are regular, you're usually still ovulating regularly. Usually in perimenopause, towards the end of it, your cycles start getting irregular, and you may still ovulate occasionally, but it's like kind of sporadic.
It's kind of like chaotic.
It's like your ovaries are like puttering out. Like they're just they're like giving like a last ditch effort here and there, but it's like kind of unreliable. But yeah, we tell people if you're worried about pregnancy, then you should still be on birth control until you're fully menopausal, and then you're not going to get pregnant.
Okay, I understand. I'm thinking more the opposite. If I just know a lot of women who are looking to get pregnant in their late 30s, early 40s. So if they've started experiencing some perimenopause symptoms, does that mean they're doomed?
I would definitely have them, if you're over 35, 40 and you're not able to get pregnant, I would definitely go see a fertility specialist, which is not me, but go see a reproductive endocrinologist who's familiar with this and can really look at all the factors. They can do an ultrasound. You can look at the quality of your ovaries and the follicles that are in there, the eggs that are in there. We can also do blood tests, like an AMH blood test can help tell you about your follicular reserve, FSH, about how well you're responding to your brain signals. So there are some tests that can be done. There's actually a company that I'm an advisor for called Timeless Biotech that has a Menotime test that's coming out soon. It's a blood test that essentially gives you within about a year estimation of when you're going to go into menopause. It doesn't necessarily tell you how long you're fertile before that. But I do think, if you're over 30, even 35, if you're starting to have some symptoms but you still want to get pregnant, don't wait years to go see a doctor. Go see an endocrinologist that can help you, or a fertility doctor can help you.
Okay. Yeah. I mean, definitely. I just didn't know if those two, like how interrelated, if menopause and fertility are, as I feel like they feel 1-to-1, and just obviously if you're fully in menopause, you're no longer fertile. But if it can be a 2 to 10 year span,
they're very related though, because the ovarian aging, which affects both your ability to conceive as well as your all the hormone production, that goes hand in hand. And so as your ovaries are getting older, the eggs are getting older. So the quality of the eggs, even if you are ovulating, are not as good. And so, even if you're ovulating as you're older, you may not be able to conceive, or at least to carry a pregnancy for very long. You may have more miscarriages because the quality of the egg is also older.
Okay, that makes a lot of sense. Can we talk about normal range versus optimal range of hormones? Because I know those are terms that are used a lot in the hormone replacement therapy space, and I would just love to hear your take on it.
Yeah, I think not. So most labs probably have an optimal range versus a normal range. And by optimal, we just mean most of the people who are healthy are in this range.
Okay.
And the reason that we have to have that is because the actual lab reference range, what they consider to be the normal range out of a lab test, all they do is they take a population of people age 18 to 90, 100, whatever, and all adults. And they say, basically, let's do a lab test on these people, and then we'll figure out what is the 95% middle ground. Like, where do 95% of those people fall? And that's the range that's considered normal. So in order to be abnormal, you really have to be in that 2.5 to 5% of the edges.
Right.
And so that's not taking into account how you feel, how you look, how active you are. Are you able to do the things you want to do? It's not taking into account anything except that you are a living, breathing person.
Right.
Sometimes they'll rule out, they'll take into account other diseases and things, but for the most part, that's what normal means. So optimal, and there isn't necessarily an agreed upon optimal range for anything. Doctors all have kind of their own optimal ranges, but we're all pretty close. We all similarly think about it in terms of where do we think you're going to feel the best?
Right.
And that's what we consider optimal.
Where you see a majority of your patients.
Yeah. Feel the best now and also prevent diseases in the future. We're also looking at what's the level that's going to help you to live healthy for as long as possible.
Well, that was the next thing I wanted to talk about is, at the risk of beating a dead horse, because I know it's discussed so much nowadays, but I still find so many people are still misinformed about this, is the whole estrogen and breast cancer conversation. And then even just the cardiac disease prevention that hormones can play.
Yeah, it's crazy. I mean, estrogen is one of the best tools that we have for women in preventing cardiac disease, which is the number one killer of women. We have studies. We have tons of studies, many observational studies, 30 plus observational studies, plus other randomized controlled trials that say if you start estrogen within 10 years of menopause onset, it reduces your cardiovascular disease risk by 30 to 50%.
Wow.
Which is huge because, heart disease is the number one killer of men and women.
Yes.
And 1 in 3 women will die of heart disease. So
I feel like we don't talk about that.
No.
I feel like that is not common knowledge.
It is
everyone
not.
is scared of cancer, of course. And I think, of course, it stands out to us because we've all lost someone prematurely due to cancer,
Yes.
right? And we think of men dying of heart attacks or having heart disease. But is that just me? I feel like we don't talk about women having heart disease.
Right. And what's crazy is that even younger women, women under 40, more of them die of heart disease than they do breast cancer.
Wow.
Even younger women die of heart disease. Certainly as we get older, estrogen protects us from heart disease. So women in general develop heart disease about 10 years after men.
Okay.
Because we have estrogen protecting us until about age 50, which is the average age of menopause. Mm-hmm. Once estrogen goes down, that essentially is when plaque starts accumulating in our blood vessels.
Right.
And so if we can stop that from happening by giving estrogen therapy, then you're just pushing off, that heart disease.
Yeah.
And then, of course, we also know estrogen reduces osteoporosis
I was just about to
risk
say.
by about 40%, fracture from osteoporosis. And that's something else we don't talk about. And osteoporotic fractures, if you have weak bones and you fall and you break a hip, you have a 30% 1-year mortality rate, which means 30% of those women who break a hip will die in the first year.
That's crazy.
It is crazy. And my mom broke her hip a couple of years ago because she'd been off of estrogen for a number of years because of the Women's Health Initiative. And she broke her hip and she's back on her feet and she's okay. But, she is one of the rare people. Most people, if they break their hip, most women at that age either die or they end up in a nursing home. Or they end up really pretty seriously disabled, and it just, they can't do the things they want to do.
And it's such a big reason we incorporate DEXA scans as part of our initial health check at Humanaut. I talk to people all the time, giving tours and just talking to people about Humanaut, why it's so important to know what your bone density is at a young age, even to make sure you're not prematurely osteopenic, right?
Absolutely. Yeah, we had a 28-year-old in the last couple of months who had pretty severe osteopenia, a woman who looked totally healthy.
Oh my gosh.
And she has osteopenia, and
why?
So we're working it up to figure out why. But you don't see or hear your bones or feel your bones until they break.
Right. No, you don't know there's a problem. It's like, it's like most things in health, right? You don't know there's a problem until you feel something. And that's such a big reason of why we're doing what we're doing, to be preventative about your health and even, like that's why I ask about at what age should you start monitoring your hormones to know, like for me, I've always found it helpful to know when I'm feeling really good, this is where my hormones are.
Yeah.
And then I know when I'm feeling bad, okay, I'm usually within the quote unquote normal range of thyroid hormones.
Right.
But with my whole mast cell thing, like my thyroid tanked. And I went from being on the high side of normal, where I was feeling really great. I was on the lowest dose of NP thyroid, to all of a sudden I was on the very low side of normal. And I could barely get out of bed in the mornings. I was so exhausted.
Wow.
So by increasing my dose, I was back up to what's normal for me.
Yeah.
And then I'm feeling good again,
Yeah.
and hopefully I can lower that as I kind of get a hold of this over time. But
I do think it's important to check. I mean, again, especially the thyroid, insulin, some of these lab tests to check and see just kind of where you live normally, when you're feeling good, like you said. It's hard to get people sometimes to go to the doctor when they feel normal.
yeah.
They're like, why would I go to the doctor? Like, why would I spend that extra time, extra money?
Yeah.
Why would I do that? But what you don't realize is that you're not going to feel this good necessarily forever.
Right.
And, it may be tomorrow that it changes. It may be 10 years from now. But getting a baseline and getting established with a medical provider that you trust, whether you see them, every 3 months or every 6 months or even more, but thinking about how to keep this good feeling going long term versus being reactive later when it happens and being like, holy cow, what happened?
Right. No,
scrambling.
Exactly. And that's, that's what I love about Humanaut as well is, there's some fun aspects of it. Like I think it's if you're competitive and you're into athletics, it's always cool to do your VO2 max and your VALD to see where you're at on both of those levels. And then even with your DEXA to know where your muscle mass is at. And, even if you're not worried about your bone density, just knowing where your fat and muscle are at are also very helpful for your own reference range of, if you love the way you look right now, let's see where you're at so that 10 years from now, if you're starting to look a little different, you know what you're striving for.
Yeah. And we have a lot of people who are also just like, they're sports people. They want to perform at their best,
right.
Or they're CEOs of companies. They want to keep their cognitive health at their best. So maybe they don't have a problem, but they're thinking about like, how do I really optimize? How do I get my VO2 max higher? How do I get my, whatever it is. And so we're having all the tools that we have with the peptides and the hormones and the, the diagnostic tests and things that we have, we're able to help with that as well.
Right. Okay. So back to hormone replacement therapy for a second. Will all people need hormone replacement therapy at some point?
I would say for women, all women could potentially benefit from hormone therapy if they don't have a contraindication. Because there are some people who can't take it. Like if you have an active breast cancer or any kind of hormone sensitive cancer, then we can't give you hormones right then.
Okay.
Potentially, some doctors won't some oncologists won't let their patients have hormones after, even after breast cancer, if it was hormone sensitive. So there are some populations of people who can't have hormones like that. But in an ideal world, would I be able to offer hormones to all women? Absolutely.
Okay.
In men, not all men need testosterone therapy because some men are still, can be in their 70s. I was just talking to a guy yesterday. He's in the 70s and his testosterone is 900 and he feels great.
Really?
Without doing anything. And
That's
so
incredible.
Some men can still make testosterone. If they have a pretty healthy life, they're lifting heavy weights, they're doing all the things, and their testes are just working well, they can still make testosterone versus some men need it, in their 30s or 40s. So men are a little different, but all women will lose estrogen and progesterone.
Okay. That's really good to know. And then why do some doctors not prescribe testosterone to women, even if they have very low levels and they are presenting with symptoms of low testosterone?
Because testosterone is a male hormone.
That's what I want you to talk about.
Because testosterone has been billed as a male hormone. Men have 10 times more than women, but women have more testosterone in their bodies than they do estrogen.
We do?
Yes. You make more testosterone than you do estrogen. And it's just we have no FDA approved testosterone, even though multiple companies have tried to get testosterone through for women, but they just keep getting told no.
Why?
I think part of the reason is that the studies that have continued, oftentimes shown testosterone to be helpful are for hypoactive sexual desire disorder, which is low libido, low arousal, orgasm problems, so sexual problems.
Okay.
So that's where we are reliably, repeatedly seeing that testosterone therapy is beneficial.
Okay.
And that's at a pretty low dose of testosterone. In those studies, that at that low dose of testosterone, they don't reliably see improvement in other things. They don't see cognitive improvements, muscle building improvements, metabolism, fat burning, mood, like all those things. So they don't see those improvements in those low dose testosterone therapy trials.
Okay.
And because women's sexual health is devalued in society, no one cares that you don't enjoy your sex life. And so for that reason, I think that testosterone hasn't gotten approved for women, even at that low dose. I think also testosterone at higher doses does help with cognitive health and muscle building and mood and all the other things we talk about, but it's at a little higher dose than what's been studied. There are studies on that and on higher doses. Dr. Rebecca Glazer, who's a breast surgeon, has done a lot of studies, and her studies show that those higher doses absolutely do benefit women full body health. But there's also associated side effects that can sometimes come with testosterone at higher doses. So people get nervous and then they just say, you know what, it's too complicated. Let's just not do it.
And what are some of those side effects? Because we're talking about all the benefits of hormone replacement therapy and having enough to be in an optimal range. But I've also seen a couple of people get a little bit overzealous and they're on a little too much.
Yeah. I mean, there's every medication, every supplement has a side effect.
Yes.
And hormones absolutely do have side effects. Testosterone, if you get too much testosterone, you can get increased hair growth on your legs, even on your face. You can have hair loss potentially. It's not super common, but hair loss in women. You can have acne. That's fairly common. The most common ones are acne and increased hair growth.
Okay.
The less common, very rare, are voice changes, so deepening of the voice, which is irreversible. If it happens, usually.
Okay.
So that's not a good one. Clitoromegaly, so swelling of the clitoris, also can be irreversible. Those are usually at very high doses and not very well, not many case reports of them.
Right.
But hair loss does happen, and we hear stories about that. So testosterone can certainly cause symptoms and side effects, and you have to be pretty careful about the dosing you're doing.
Yeah, and it's, to be clear, it's not, I've never spoken with a patient of one of the practitioners I work with or refer to or respect who have patients who have really suffered anything beyond, I got a couple of facial hairs and we went back down a couple of points and all is good. But yes, it's with that, testosterone is a controlled substance for a reason. And I think, especially people, whether it be with addictive personalities or if they have, whether it be extreme fitness goals, they really overdo it.
Yeah.
And you can, have side effects. Or are there any disease, is there any disease concern with overuse, with overprescribed hormones at all?
I mean, with estrogen, overprescribed estrogen, you can certainly get endometrial cancer. So cancer of the uterus, the lining of the uterus, which is why we always give progesterone with estrogen, because we know that too much estrogen can cause that. Too much estrogen is also a player in breast cancer.
Okay.
So I say that knowing that estrogen therapy bioidentical estrogen therapy does not increase breast cancer risk in the studies that have been done.
Right.
However, we always give progesterone. I always give progesterone with estrogen. Not everyone does. If you have a uterus, you have to take progesterone.
Okay.
If you don't have a uterus, many doctors skip the progesterone,
Okay.
which I think is not ideal, because progesterone is like the yin and the yang to estrogen. But estrogen does affect your breasts. It can cause breast swelling. It can cause breast symptoms, and over time, if you have too much estrogen, it can be something that it influences breast cancer.
Right.
So this is why it's interesting. I have a lot of women, kind of followers on social media, who they get really mad that they have to have a doctor or a medical provider to take these hormones, because they're like, these people are gatekeeping my hormones. But these hormones actually are dangerous if you do them the wrong way.
Yes.
And it's not just symptoms. It's not just you're irritated and you're bloated and you have to, your pants don't fit for a little while. These hormones actually can be dangerous if they're done the wrong way, or it's the wrong kind of hormone, which we learned about from the Women's Health Initiative. If you give the synthetic form of progestin, then it's a disaster, that causes all kinds of problems. So, we've learned a lot, and I think now it's just about getting enough doctors educated, because we still don't have enough of that. And currently only 5% of women, less than 5% of women over age 50 are taking hormones in the U.S. right now.
5%?
Less than, yeah, it's like 4.5%.
Really?
It's very low. And part of that is there aren't enough doctors that know how to do this.
Yeah.
And so I definitely think we got to do a better job of that. But you have to, you do have to have a doctor with some training in this.
Yeah. No, it's so important. And it comes back to that optimal range. And it's like, I don't want to concern anyone who's considering hormones that, oh, I don't want to get on too much because then I'll be like, your risk is likely a lot larger that you don't have enough.
Yes.
Than the risk that you could potentially get too much. And that's just why it's important to work with a very trusted practitioner. Shameless plug, like ones at Humanaut.
Right. Yes.
To get yourself in an optimal range, because not only will you feel better, but you will be in a more disease preventative state as well.
Yes.
What are your thoughts on estrogen cream applied to the face?
There's some decent studies that estrogen cream can be helpful. We know estrogen in general is good for the skin, and that one of the major causes of skin aging in midlife is loss of estrogen, because estrogen stimulates collagen in your body. So when you lose estrogen at menopause, you lose about 30% of your collagen throughout your entire body, including your face. So there are some good studies that estrogen is good for skin. In the low dose that we give it as a cream, it can help skin.
Okay.
So I think it's one of these things. There's small studies, so we're still learning.
Okay.
But certainly there's reason to believe that it's effective.
Do you use it with your patients?
Yes.
You do?
Yeah.
Okay. All of them, or?
Not all of them. If you're taking a high enough dose of estrogen in your body, you may not benefit from extra estrogen on your face. Okay. Same thing with vaginal estrogen. Like, it's great for the pelvic floor, but if you're on a pretty high dose of systemic estrogen that affects your whole body, you may not need extra estrogen like applied vaginally. Okay. But in some cases you do. And so I think that it's pretty individualized. But yeah, I think it's a great tool, as long as, if you're having symptoms of skin aging or vaginal aging, just to add that in. What's
your go-to delivery method of estrogen for systemic?
I like several different ones. Okay. Transdermal creams or patches are the most common. Okay. And they're the safest. They don't increase blood clot risk. They work really well. Oral estrogen, which I actually still give quite a bit, like pills, has the most evidence behind it for preventing heart disease, for instance. So I think creams and patches probably do the same, but we just don't have the data on it yet. Okay. And oral, we do have data on. So I like oral, but it can increase blood clot risk a little bit. Mm-hmm. And then I also use other compounded forms too. I'll use troches, like sublingual forms of different hormones. I don't use it as much for estrogen, but I'll use them for progesterone or testosterone. Okay. So there are a number of different forms that we can use for all of these hormones. Okay. And one thing that's important is understanding the benefits of each form, and potential downsides of each form, and that there's different doses depending on each form and each hormone. Like, I'm writing a medical provider training course right now on this, and it is so complicated. Like, every single form has a different half-life and a different peak level and a different time to peak level, and it's like you have to know all of these things in order to really be able to prescribe well. Right. But the great thing is that usually, once you understand it, the doctor or medical provider can help you figure out what the best form for you is. Okay.
What's your stance on pellets?
I don't mind pellets. Okay. I did pellets for a number of years for patients, mostly testosterone. I don't tend to use estrogen or progesterone in pellet form. Okay. I did use testosterone a fair amount, and I actually loved it mostly for women. Okay. Who I found that it worked really well in keeping their levels very stable over three months or so.
Oh, really?
The downside to pellets is that if you give them too much, then you can't take the pellet out. So they're stuck with those symptoms for 3 to 4 to 5 months, which is not great. The other downside is there's a risk for infection, which I never saw. I did hundreds of them. Or there's a risk for your body to push the pellet out, which is called extrusion, which I saw once. So those things don't bother me, but I do think that the risk of side effects is not great. But they're great for people who travel a lot or people who are in the military. So I'm not anti-pellets like a lot of doctors are. They're not my first choice usually.
Right. Yeah, for me, what we've experienced with patients is typically when you're starting out on hormones, it takes a little bit to get your right dose. Yeah. So I always question people about it, because I'm just interested in the experience, because it's, if you don't have enough or you have too much, you're stuck with it, which is like, for me, I would be a little like, I don't want that. I want to be able to adjust it as like day to day.
If it's not enough, you can always take a little bit more. But if it's too much, like you can't go in there and really get those pellets out. Like it would be a whole mess to do that. So.
Yeah. Okay. I asked some menopausal friends if they had any questions for you. And one was, is there a certain age that you would suggest women start using vaginal estrogen cream to avoid vaginal dryness? And is vaginal estrogen cream necessary or always an added benefit if you have an estrogen patch?
I love that question. I believe that all adult women need estrogen in their vaginas in some form. Okay. So either they should be making their own estrogen, or we should be giving it to them.
Okay.
So that's all adult vaginas need estrogen.
Right.
Is what I say. So in terms of what age, I mean, it depends on when you're going into that menopause transition. You could be 40, 45, 50. But if once you have lost some of your estrogen supply.
And how would you know if you lost some of your estrogen supply in your vagina?
I mean, you would have symptoms potentially like lack of lubrication, pain with sex, increased UTIs. You're getting bladder infections more regularly, or like you're having a little bit of bladder leaking, like a little bit of urinary incontinence, like you're jumping or sneezing and you're leaking more urine than you used to. Those are common symptoms. You could have itching, you could have vaginal discharge. There could be a lot of different things. Okay. But if you're in that kind of age group, then vaginal estrogen is a no-brainer because it's so safe. Even in breast cancer survivors who've had hormone-sensitive cancers, super safe. Even in people who've had strokes, it's super safe. Like we have studies on all this.
Oh, wow.
It's a low enough dose that it just stays in your pelvic floor. Okay. So it's not it doesn't affect the hormone levels of the rest of your body.
Okay.
So I think about it like a patch, for instance, is you're giving estrogen over your whole body. Mm-hmm. So it's kind of like a sprinkler system that's sprinkling the whole body with water, right? The whole lawn, versus a vaginal estrogen is like you're hand watering just like the little petunia dishes, bushes over on the side. Okay. Like you're not, when you hand water those petunias, it's not getting into the whole rest of the lawn.
I was going to say, so you're never giving someone vaginal estrogen and that's their estrogen dose systemically?
No. Okay. Because it doesn't affect the rest of their body. It's just affecting the pelvic floor. Okay. And we do know that giving vaginal estrogen in people who are already taking estrogen still has benefits oftentimes. Now, certainly if you're on a very high dose of systemic estrogen, you may not need it. But if you're on a kind of normal or like medium dose of estrogen in your body, then adding vaginal estrogen is oftentimes helpful.
Okay. So you would know if you don't need it because you're not experiencing any of those symptoms you have?
Usually, yeah. As if you're paying attention and you have none of those symptoms and you're also on systemic estrogen, then you're probably fine. Okay. But if you're having any of those symptoms, including, again, like repeat UTIs, bladder infections, which people don't think about as being a low estrogen thing, we can reduce those by about 25 to 70% just by giving vaginal estrogen like 3 days a week.
Wow. I think of, I had 3 grandmas, and I think towards the end of all of their life, they had frequent UTIs. And I wonder if it could really help with that, I'm sure.
Yeah. And what's great about vaginal estrogen is you can start it at any age. You can be 85 years old and start it, and it works. Right. Which is a little different than some of the other hormones. Like they don't all work all the time, but that one works even if you start it late.
Really?
And it takes about 12 weeks to see benefits. But like my mom is 79, and I mean I've asked her several times to start vaginal estrogen, but she's finally like, okay, I finally will.
Really?
And so I just got her on it recently. So I mean, I think we could prevent so many of those urosepsis, those bladder infections that turn into kidney infections that turn into sepsis and put you in the ER. We could prevent those with vaginal estrogen.
I love that. Switching over to a little, like the more regenerative and integrative side. So obviously at Humanaut we have regenerative therapies like stem cells, hormones, which we've talked a lot about. Can we talk about how peptides fit into this conversation of longevity and optimal life and performance? Yeah,
so peptides are just little short proteins. Okay. They're just short strings of amino acids. So they're very, kind of simple in the way that they look. And they're, your body makes peptides all over your body, and they do very specific things depending on, which receptors they're working on. Mm-hmm. So when we talk about peptide therapy, it's a very big group of, of things that we're pulling from. It's like saying medication therapy, right? Like people are always like, what is peptide therapy? Like, what's the one thing it does? And I was like, well, I don't know. What does a medication do? Right. It's kind of a similar idea. But what's unique about peptides are we're mimicking what your own body already has, is already using in these, very kind of small amino acid change. And so we can do, all different things. You could use peptides to improve healing of your muscle pain, to help you bounce back after sports recovery, to help with your brain health, to help with sleep, to help with sexual function, to help with skin. So there's different peptides for different, parts of the body and different processes, but they're coming from natural sources. Like they're coming from what your body is making.
Okay. That's super helpful to know. And so, as you said, you could use one like BPC 157 to heal an orthopedic issue happening. I know it could also be very helpful orally for gut issues, for example. As the skin and sex expert, which are your go-to peptides for skin and then for sex?
For skin, I like BPC actually for skin.
Oh, yeah.
I also like GHK copper, which it can be a topical for skin and hair, or it can be like injected as well.
Right.
That's a great one for skin. And, for sexual health, PT 141 is kind of like the go-to for sexual health.
Okay.
It does improve libido, and it can be really powerful, but it also can have some nausea. So it's like one of these that I like it, but I also, it may make you sick.
Okay.
Like it can work, but make you sick. But that one it's similar to, you've heard of melanotan, right? The one that makes you tan.
Yeah.
So what they found was melanotan makes you tan, but there was a part of it that would also improved sexual desire.
Really?
Yeah. And so people who are taking this were like, oh my gosh, I'm not only tan, I'm also I'm have a high libido. Like, this is amazing. And so they separated out the part of the peptide that caused the desire part. And it's actually called bremelanotide is the formal name.
Okay.
Bremelanotide. And that's what is PT 141. So essentially it's part of this melanotan molecule. But anyway, it's interesting. It doesn't always agree with people, but I think it works well. Or even just the growth hormone secretagogues, the ones that increase your own growth hormone production, like tesamorelin or ipamorelin or CJC 1295, that increase your growth hormone. That can also help with your sex drive also.
Really? Okay, I guess that makes sense.
Yeah.
More growth hormone, it increases your
that one
sex
kind of
drive.
like peps up your whole body.
Yeah. So what's typically your go-to if somebody's, say, suffering with low libido? Would you start with a growth hormone peptide or the other one?
I'd start with testosterone probably.
Okay.
But if I have that dialed in, then I would probably give growth hormone first, or growth hormone secretagogue. But I do PT 141 can be really effective.
Yeah.
It's the other problem with it is it has a very long half-life, so it can be effective for 6 hours.
Okay.
And which is great, except I've had people call me and say, I was up all night, really aroused, all night, being oh my gosh, it's too much.
Oh, that's funny.
So you don't really know when it's going to strike.
Their partners are like, enough.
Yeah, it's not like it hits you right away. It can start anytime in the next 12 hours. And so you have to be ready, okay, I'm ready for this to hit. Whenever it happens, I'm ready.
Today is sex day.
Today's sex day. Putting everything else aside. No other jobs to be had. I'm just ready.
Okay, yeah. That's good to know. That's really good to know. So we talked about stem cells for sexual health early on, and I know that it can be very relevant. I mean, we were talking about younger people can have these issues as well as menopause. I think it's very common in menopausal aged women especially.
Yeah.
How about post childbirth? Because obviously childbirth, if you have a vaginal birth or C-section, can be very traumatic on your sexual organs. Can you use stem cells for recovery from that?
Yeah, I say yes. There's not a lot of research on it.
Okay.
There's not a lot of research in general on women's sexual health for using regenerative therapies or other therapies.
Right.
There's research for specific other problems, but not sexual improvement.
Right.
So we don't have a lot of research, but I believe yes. I believe that these therapies are going to always be improving blood flow, supporting healthy tissue growth and formation, and that there's no reason that wouldn't be true in a person who just given birth.
Okay. Have you done it on anybody to recover from childbirth?
Yeah. I like them to get not right away. I like them, let their body recover, let them hang out with their baby, but certainly a year or two later, if they feel
what would
like
be
things,
the time frame?
I just want, your body's amazing at recovering. And so let your body work its magic. But then, once you're down the road a little bit, a year maybe, there's no set number, but you're down the road and you maybe want some extra help, then I would think these therapies can be great.
Okay. Awesome. And are you just injecting like straight into the vaginal canal?
I personally usually do 2 spots into the vaginal canal, like upper, kind of anterior upper kind of wall, like where the G spot is, kind of in that area. And then I'll do the clitoris also.
Okay.
And then in some cases, if someone has other issues, like with the, inner labia or something else was going on, then I'll inject those areas too.
Okay. And do you use like laser therapies for this kind of stuff as well? Or not really? Like I know there's some like radio frequency
I've
treatments.
tried a bunch of different ones.
Yeah.
I did use radio frequency for a few years. I've done the CO2 lasers in the past. And
ooh, CO2?
yeah, there's like the Femi lift it's been around for a while.
Oh, okay.
I just don't think, I wasn't as impressed with them as I wanted to be. And so I
Really?
ended up just stopping. I think there's probably a place,
Okay.
but I think that they're not my go-to anymore.
What is your go-to?
My go-to is vaginal estrogen if you need it.
Okay.
And then I love shockwave therapy.
Oh, okay.
So the low intensity shockwave therapy, which is fantastic. We have lots of studies on men's sexual health, like really well documented improvement in blood flow, tissue health, et cetera, for men. Less studies for women, but early indication that it's fantastic for pain disorder, like pelvic floor pain disorders, and as well as probably improving arousal and pleasure and things like that. And then I also like the regenerative injections.
Great. Okay. So can we use the soft wave for
Yes,
okay.
100%.
For female as well?
Yeah.
Okay, wonderful. I knew we could use it for like erectile dysfunction, but
Yes, and I have protocols. I'll make sure you guys get them.
yeah. Okay, great. One of our guiding principles at Humanaut is that true health span isn't just about the body. It's about mind and spirit. How do you incorporate that holistic view as part of our patient care?
Oh, that's a good question. I think it comes down to a lot of things that, like, just the feel of the clinic, I think is part of it. Like you feel in this safe space, this calm space, this beautiful space, the interaction with the medical providers as well as the rest of the team, whether it's a health coach, whether it's the person in the gym who's helping with your workouts, your trainer, your exercise physiologist.
Right.
I think that all of those things are going to support that healthy mental, emotional, spiritual side of medicine, and then also giving you tools to work on that side at home, whether that's journaling or deep breathing or walks in nature or breath work, or there's so many different tools that are out there that we can help guide you so you can work on those in your own time also.
Love that. Yes, the setting at Humanaut is very pleasing, which I think it's part of that holistic experience.
Yeah.
It really sets the tone.
Yeah.
For someone listening who wants to feel and perform better as they age, if you had to choose the top 3 things you recommend they focus on to start, what would it be?
It's boring, but I always go back to the basics for the top things. I mean, sleep is is probably my number one.
Really?
For me personally, sleep is the most important thing. Sleep, food, movement are probably your top 3.
Yeah.
I want to throw in a 4th, which is social interaction.
Okay.
Because I think that we know from studies that, social interaction and that feeling of kind of belonging is actually a stronger health indicator than anything else that we have. It's more important for longevity than anything else. So that's the 4th thing.
Right. That's been the biggest takeaway from the Blue Zones, right? That it's your community and your sense of belonging.
And the Harvard study, which has been going on now for a long time, shows
Right.
that strong social interactions are more important than not smoking. They're more important than not being obese. They're more important, like any of the things that we thought were important, which are, but strong social interactions are even more important.
Right. I love that so much. Okay. Where do you see the future of regenerative and integrative medicine heading in the next 5 to 10 years? And how do you envision Humanaut leading the way?
I hope at some point that integrative medicine and functional medicine and regenerative medicine is just like part of medicine.
Yeah.
Like I hope that it just gets integrated into like regular allopathic medicine. And that, when you go to the hospital, they're pulling from all of these things that we're already doing, these sort of tricks.
Yes.
I don't know that that's going to happen, or at least not anytime soon, but I'm hoping that Humanaut can kind of lead the way in showing how we can make these therapies more accessible, how we can bridge both traditional medicine with this kind of other medicine, this integrative medicine, like pulling the best of both worlds and not necessarily having to choose one world or the other, and also bringing forth these cutting edge therapies quickly and not waiting 10 or 15 years before therapies get adopted once they've been shown to be safe and effective.
Right. Yeah, I couldn't agree more. I mean, what a dream that would be if you went into the hospital and, not only could come away with a prescription, but with some lifestyle recommendations on how to live healthier.
Can you imagine?
I really hope that that's the direction we're headed. I have to believe that it is. I feel like, or else it just feels hopeless. But,
Can you imagine having red light therapy beds in a hospital? Just being able to take a few minutes, leave your hospital room for 10 minutes and go lay in a bed. I just feel like it would be so great to have some of these tools in just a regular hospital.
Yeah. I have kind of an offhand question for you, and we can cut it out if you don't want to answer it. But what's your take on home births versus hospital births?
I, as a ER doctor,
right,
who saw a lot of things go wrong, I personally would never have a home birth.
Okay.
I think that I don't think there's a problem with it. I'm happy if it works for you, but I personally would want to be in the hospital. Yeah. I think that midwives are great.
Yeah.
Doulas are great. Coaches are great. I think that there are some great tools that you can add so it's not quite so clinical.
Right.
But I've just seen too many things go wrong to want to be outside the hospital.
Yeah. Yeah. Clearly you can see where my head's at these days. Yeah. So I'm polling all the people whose opinions I respect. And that's not surprising, of course. Yeah. You've seen the worst. So.
Exactly.
Yeah. I think we're going to go hospital birth I'm not pregnant, but when the time comes, at least for the first one.
But there are some hospitals that do a really good job, though. Yeah. Now they're very beautiful rooms, and they've got the tub in there. They try to make it feel a little bit more like home, which I think is really nice.
Yeah, I would love that. I'm going to need to find that. My last question for you is, what is one non-negotiable in your daily wellness routine?
Sleep.
8
hours of sleep.
Okay.
Is my non-negotiable.
I'm so happy to hear you say that, because I feel like Jim was an example. We talked about sleep with him, and he's like, yep, I need 6 hours. And I'm like, ugh.
No.
It makes me feel so I wish I could operate on 6 hours. I really do. I'm someone who wants to I want to maximize all of my time. If I sleep for any less than 8 hours, I feel like crap.
I do. And I went years. I went, 2 decades sleeping low amounts and for crazy amounts, in the ER, having kids, all that. So I could do it, but I just don't feel good.
Yeah.
And if I don't sleep well, I don't want to exercise. And then if I don't sleep well, I don't want to eat well. And if I don't sleep well, it triggers everything else to go down the wrong side. So
I feel the exact same way. It's exactly, I don't want to exercise, and then if I do exercise, I find that exercise exhausting.
Yep.
And then I'm over caffeinating, and then I'm burning through my food so quickly.
Yep. And I'm hungry, and I'm eating too much. And
Yes, it's this cycle, and then I'm moody. All right.
Well, you and I both need 8 hours. That's good.
It is good. I think and I said that to Jim, I think it's a male versus female thing a lot of times as well, that as females, I think we just need a little bit more sleep, and that's okay.
That's okay. Yeah.
Yeah. All right. Thank you so much for being here. Where can people find you?
So I'm very active on Instagram, Dr. Amy B. Killen, and all the social channels, but Instagram's kind of my little home base. And then I'm also at dramykillen.com. That's my website if you want to learn more about mostly women's health on the website. And then, of course, at humanauthealth.com.
Yes. And at Humanaut Health and at Humanaut_FL.
Yes.
If you want to follow all of our
the
accounts.
Humanauts.
Yeah. All right. Thank you so much.
This
was great. This podcast was brought to you by Pureform, a comprehensive wellness center in Boca Raton, Florida. The website is pureformhealth.com, or you can find us on Instagram at pureformhealth. Feel free to message us with any questions, and note that you can connect with our providers for consultations over Zoom, from everything from stem cell therapy to hormone replacement therapy and peptide therapy. That's it for this episode of the HealthSpan Collective. We hope you found it insightful and inspiring. Don't forget to follow us wherever you listen to podcasts so you never miss an episode. And if you enjoyed today's conversation, we'd love for you to rate, review, subscribe, and send it to a friend. We'd also love to connect with you on Instagram. Follow the podcast at HealthSpan Collective and me at Nicole J. Doran. And leave us a comment on our latest post, letting us know what you'd like us to cover next.